It's a paradox that we know that people with psychosis, with schizophrenia, are acutely sensitive to social stress. And yet, as you've just outlined, we often place them in places which are extraordinarily stressful, hostels with drug abusers there, or places where they're in poverty. They're in the most difficult part of town. They're socially isolated. These are conditions that most of us would struggle to cope with.
Welcome back to the Thinking Mind podcast.
Today we're going to be talking about a subject we haven't really tackled in great depth so far, and that is the subject of psychosis and schizophrenia. And I wanted to tackle this subject quite carefully because there's so much misunderstanding about what schizophrenia and psychosis is in the public sphere, and what are the different factors that might contribute towards developing or not developing this disorder. What are the signs and symptoms which typically manifest? How dangerous or not dangerous are people with psychosis? What's actually going on in the brain? What are the different treatments available? What's the kind of prognosis if you've had a problem like this, which many people have? It affects, around 1% of people in the general population, if not more. And with me to talk about the subject is one of the most cited psychiatric researchers globally and the most cited psychiatric researcher in the UK. I'm talking, of course, about Professor Robin Murray, who's been studying schizophrenia for the majority of his career and was one of the first researchers to suggest that schizophrenia is a neurodevelopmental disorder. That is to say, that's a disorder that develops as a result of a dynamic process that affects the development of the nervous system, and that there'll be all sorts of factors involved, as we discuss, genetic factors and various environmental factors. The other reason I wanted to tackle this topic is because, like a few disorders, schizophrenia is there's a lot of mystery surrounding it, and that's because people who have this disorder are often very socially reclusive. So unless you work in mental health, or you have a family member or a friend who has this condition, people don't know a lot about it. People with schizophrenia are often in their homes for the majority of the time. And so I think that sense of mystery only serves to increase stigma, increase taboo. And one of the things I want to do with this conversation is try and disentangle that. I think with less mystery, there's more understanding and more empathy. So hopefully you can get that from this conversation. So without further ado, here's Professor Robin Murray. Professor Murray, thank you very much for coming on the podcast today.
Pleasure.
Obviously, there's a lot to talk about. We haven't done an episode on this podcast about psychosis or psychotic disorders like schizophrenia yet. But before we dive into that, I was wondering if we could talk about how things are at the moment, how you're dealing with the current situation in terms of coronavirus.
Well, essentially, I am hiding in my house. So I talk to patients by Skype, and they can do a bit usefully there. But because I'm high risk, I'm prevented from going and seeing patients. My wife goes in to see patients, and so she's living in our upstairs, and I'm living in the downstairs.
Have you found much of a difference talking to your patients, interacting with them remotely versus in real life?
No, I've been very surprised how relatively little difference it seems to make. Of course, most of my patients are people I've known for a while. I'm not seeing patients, well, one or two patients I'm seeing for the first time. But on the whole, it seems to me that we're going to learn that we're going to be able to do this much more frequently. And that, for example, community psychiatrists are tramping across big cities, spending a lot of time in buses or motorbikes, when they might well be able to avoid this by talking by Skype or Zoom.
Yeah, it seems like so many industries are having this collective awakening of there's so much potential to do stuff online now, and I imagine with the economic ramifications of what's going to happen, the world might look very different after this is over.
Of course, yes. Yeah. But it would be nice to think that caring professions would be more valued and bankers less. But
that would be good.
We said that before 2009, and it didn't happen.
Yeah, I think it's hard to get past our short-term memory as a species sometimes. Moving on a bit more to your work and your field, you're primarily known for research, as I mentioned earlier, in psychotic disorders like schizophrenia and disorders like bipolar. What is it that drew you to that particular area?
Really, because if we could understand how people become paranoid or how people develop delusions, how people have the strange experiences that they do when they're psychotic, that we might learn a bit about the normal functioning of the brain and the mind. And of course, it is utterly fascinating to listen to people explaining their experiences and how what we think of as hallucinations, people are absolutely convinced that they really heard this voice or saw this person. And similarly with delusions, at what point does an unusual idea become a delusion? So all of these things I've been fascinated by.
And I think I consider it an important public service that, because there's so much misinformation and misconception in the mainstream media about what psychosis is. From your point of view, how would you summarize psychosis to a layperson?
Oh, I don't think it's very complicated. I think it's just, by and large, people are psychotic, or we consider them psychotic, if they hear or see things which are not really there, and or they have strange ideas which are not justifiable by the facts, and which they're impervious to logic and behave in a bizarre way. So it's not a disease. It's merely what psychiatrists term a cluster of symptoms.
Mm-hmm, like a syndrome.
Yes, exactly.
And obviously, there are many conditions that can present with this cluster of symptoms. So schizophrenia is the classic example, which would be more of a psychosis that's long-standing or that can recur, perhaps with periods of wellness in between.
Exactly. So schizophrenia is just severe psychosis that has a tendency not to go away.
And what do you think are the contributing factors to developing a condition like schizophrenia?
Well, when I started in psychiatry, we knew hardly anything about the causes of psychosis or of schizophrenia. And that's one of the remarkable things, that we now know pretty well what the causes are. Well, we call them risk factors. And we know that there's a genetic contribution, and we know many of the susceptibility genes. And we also know the environmental factors, or many of the environmental factors. We know that adversity during pregnancy or at time of birth, prematurity, hypoxia will double your risk of psychosis. We know that being abused in childhood increases your risk of all psychiatric disorders, and psychosis and schizophrenia is no exception. We know that people who are migrants and their children, we know that people who live in the inner city, these factors increase the risk. We know that cannabis use, heavy cannabis use, and use of some other drugs like amphetamines can push you into psychosis. And we know that adverse life events, particularly of an intrusive nature, can again precipitate psychosis. So when I started, we didn't know any causes for schizophrenia. Now we have almost too many causes.
Mm-hmm. And so, starting with the genetics, it's important that people understand that unlike some conditions where it's only one or maybe a few genes that govern the risk of developing a certain illness, with schizophrenia, it's many genes, isn't it, that can contribute to its development?
Yes, so it's what's called polygenic. So there are lots of little genes. And again, that's a big change from when I started at the Maudsley. There was perhaps they had the most famous genetics unit in the world, run by a man called Slater. Well, he just retired. And he believed that schizophrenia was caused by one big gene. And this was fully expressed in people who developed the illness, and half expressed, partly penetrant, in people who were schizoid or paranoid. And this turns out to be totally wrong. And I think because patients felt that genetics was singling them out to be different, our patients have been very skeptical about genetics, because they thought it was demarcating them as different from the rest of the population. But in fact, it turns out that the modern genetics is showing that they're not different from the rest of the population. We all have so-called schizophrenia susceptibility genes, just that some of us have more than others. So in some ways, the best evidence that psychosis is at one end of a spectrum, and that schizophrenia is at the extreme of that spectrum, comes from the genetics.
So it's fair to say that we're all somewhere on the genetic psychosis spectrum, and depending where we are on the genetic spectrum, and then depending on what environmental events occur to us, that will influence the likelihood of developing this disorder or not.
Exactly. And of course, one of the interesting questions is, why do genes that increase your risk of, for example, being more paranoid, why do they persist in the population? Well, I think you and I probably know that if you live in South London, it's probably sensible to have some genes that make you a little suspicious of or a little cautious, that wandering around South London or parts of South London at 12 midnight, you should be a little cautious. So it's I always think what it's interesting would be interesting to study people who have what's called a very low polygenic score. So people who are prone to psychosis have a high polygenic risk score, but very interesting to see what people are like who are at the extreme other end. People who are extraordinarily lacking in suspicion and maybe a little gullible.
So what you're hinting at essentially is the idea that there's an evolutionary advantage to paranoia, and that is why these traits have persisted in our gene pool.
Yes. You probably don't know your Scottish history well enough to know about the Campbells and the MacDonalds.
No.
So the MacDonalds were a very peaceful clan who were happily living in their glen in the Highlands, and some Campbells came along, and the MacDonalds invited them to stay with them, and they stayed for, I don't remember, a week or 10 days, and they feasted and they enjoyed themselves. And then one night, the Campbells woke up in the middle of the night and cut the throats of the MacDonalds. So I think the McDonald's didn't have enough susceptibility genes. They weren't sufficiently suspicious.
Yes, even though paranoia can obviously contribute to your unhappiness, it might confer a survival advantage.
Yes. And sadly, I think if you look at international conflicts are often driven by paranoia. I remember speaking to a United Nations diplomat, and he said, yes, when you're getting two warring factors together, you're initially not dealing with the reality of the dispute. You have to deal with their paranoid ideas about each other.
Is there a scientifically studied link between population density and paranoia? Well,
we've tried to look at that, and we have. I suspected that there would be. I mean, there is a relationship between population density and psychosis or schizophrenia, and therefore we rather expected that this would be driven by paranoia. But when we looked in the general population to see whether paranoia was particularly associated with living in urban settings and in densely populated places, we failed to find that. So it may be that the studies weren't very good. The other thing, of course, is that I guess you asked the question because it's generally thought there's a relationship between urban density and schizophrenia. And that is true. That's in all the textbooks, that's is the case. But that just turns out to be true in Northern Europe. If you look in London, the incidence of psychosis and of schizophrenia is much higher where we work in South London than it is, for example, in Cambridge or Lincolnshire or Dumfries. But if you look in Southern Europe, if you look at the relation, if you look at Italy, for example, that Palermo, which is a big city with about 1 million inhabitants, the incidence of psychosis is actually lower than it is in some northern Europe, northern Italian cities like Verona. So it may be that this is something that only occurs in northern European cities.
Mm-hmm. And is there any positive explanation for why that is, or does it still remain mysterious?
Very difficult. I mean, there are both biological and social explanations. I guess one is that you can become very socially isolated in northern European cities, places like Paris and Amsterdam and London. We all know that you can become socially isolated in a block of flats in Peckham. And again, my wife, who comes from Palermo, she says in Palermo, in Sicily, there is no social isolation. There is only social intrusion. So that's one possibility. Another possibility people have looked at would be pollution. And could that explain why there's a higher incidence in big cities? Well, we've done a study where we found that the incidence of psychosis was much lower in Madrid than it was in London, whereas pollution at that time was actually worse in Madrid than in London. So I think it still is a mystery.
Mm-hmm. So there's all sorts of factors at play, which I suppose is one of the things that makes this disorder so complex.
But equally, if you were to be a cardiologist and studying a myocardial infarction, you would have to study genetics of hypertension, of thrombolytic enzymes, and then the effect of obesity and the effect of cigarette smoking and the effect of exercise. So I think in medicine, we're quite used to complex diseases.
And I think we're starting to realize that really what we deal with on the front lines, as it were, is a collection of outcomes. like schizophrenia is an outcome of sorts and a myocardial infarction is an outcome.
Exactly.
And that each outcome can be arrived at through so many different means with so many different variables at play and different proportions of those variables at play in different individuals. Again, in terms of the genetics, how far away do you think we are from a point where we can test a patient's genetics to determine their risk for developing psychosis?
Well, we can test a patient's or a person's risk at present. And we know that people who are in the top 10% for polygenic scores are 7 times likely to become psychotic than people who are in the bottom 10%. So we can test that risk. But of course, that just means that your risk might be something like 7% rather than 1%. So it's not, we would be wrongly telling the other 93% that they were at high risk of psychosis. They are a bit higher risk of psychosis, but it's not sufficient to do anything with clinically. So I think as the genetics advances, we'll get better at doing that. But I think for the foreseeable future, it's unlikely that I don't think it could be possible to screen the population and show who is particularly at risk. There may be some certain circumstances where it might be useful. For example, if there is a family with several members who are schizophrenic, who have a diagnosis of schizophrenia, schizophrenic disorder, and one adolescent child seems to be having a particularly difficult time and strange behavior. And of course, the family don't know whether this is due to the psychosis risk or whether this is just a normal or a difficult negotiation through adolescence. Then it might be useful to do a polygenic risk score, not necessarily because it would show that there was a high risk of developing psychosis, but because it might help to exclude the possibility. It might help to reassure the family that this is just some transient behavioral problem, and this young person is unlikely to develop psychosis.
So it could be useful in some specific cases. I suppose part of the problem with a population level screening is just the extent to which the environment is contributing to the development of the disorder.
Yes.
Is it still fair to say that the environmental factors account for about 50% of the risk towards developing these conditions?
Well, it depends on what kind of statistics you use. Geneticists use the statistic of heritability, and they suggest that the heritability is between 60 and 80%, and the environmentalists like population attributable fraction, which increases the apparent size of the environmental effect. But I think until we know better, it's perhaps sensible to accept what you say and say maybe half and half. But I should say that perhaps, at present we talk about the polygenic risk score. That is the summation of all the SNPs, which seem to be markers for genes contributing to schizophrenia. But we discussed earlier that there are different environmental factors. It seems to me that the genes which will make you susceptible to child abuse and make you more likely to go psychotic following child abuse may be quite different from the genes which make you susceptible to going psychotic after using a lot of cannabis. So It could be that there are different subsets that make you, well, even with the substance abuse, I've always wondered and thought it would be a very amazing study. You couldn't do this ethically, but if you took 100 young men and you gave them high doses of amphetamine and looked to see who went psychotic, and then some months later you got them back and you gave them high doses of ketamine, and looked to see who developed a brief psychosis. And then you brought them back another few months later and gave them a THC, the active ingredient of cannabis, and looked to see who had a transient psychosis. Do you think it would be the same? It would be the same individuals each time, or would people respond? Do people have susceptibilities to particular drugs that affect the particular way that their glutamate system works, or their dopamine system works, or their endocannabinoid system works? We just don't know that. Sadly, we could never do this study.
No. And I suppose that's one of the things that might lend credence to that idea is the fact that different antipsychotic drugs seem to work differently in different patients, which would presumably indicate that there's a different underlying mechanism in different individuals.
I don't agree with that, actually. I think all antipsychotic drugs, with the possible exception of clozapine, have the same effect. They're all dopamine blockers or dopamine partial agonists. So essentially, it's the same drug every time, but with different side effects because of more or less histamine blockade or more or less serotonergic effects. So I think we do know that if you give somebody with their first episode of psychosis and you would give them risperidone and they don't respond too well, then the chances of them responding to olanzapine or amisulpride are not that high. That it's not as if, I mean, I have hypertension, mild hypertension, and I take 3 different drugs for that. Fortunately, that resolves it. But each of these drugs has a different mode of action. Commonly in medicine, you're using several different drugs to affect a condition. But in psychosis, there isn't much point of it because they all have the same effect.
And just so people can get a rough understanding, once people do develop psychosis, what is going on in the brain in that individual?
Well, I think the best evidence we have is that there is dysregulation of synthesis of dopamine in the striatum. And we know from work in the Institute of Oliver Howe in particular, that people who are in the prodrome begin to show an excessive synthesis of striatal dopamine, presynaptic, and then as they go psychotic, it gets worse. And not in everybody, but this tends to be, in some ways, the final common denominator. So I'm not saying that people have an intrinsic deficit in their dopamine dysregulation, but perhaps as a result of their experiences in life, that some have become more susceptible to this.
And so the idea is that one of the functions of dopamine in that part of the brain is to regulate things like salience of environmental stimuli and meaning. And when there's an increase of this dopamine in that part of the brain, individuals tend to start seeing meaning where they shouldn't.
Exactly. And we know that dopamine is very important in new learning. And so some disturbance of dopamine may make it more likely that an individual may jump to conclusions or may come to, certainly will have strange experiences. And if they've had a particularly difficult life in which they've had a lot of adversity, they may interpret these experiences in a paranoid way.
Mm-hmm. So it's a lot about pattern recognition and perhaps seeing patterns where they don't exist. So like we mentioned earlier, some people might have a predisposition for that, and that might confer a survival advantage. But this is that process going out of control where all of a sudden you might be hearing something on the radio while you have too much dopamine in that part of the brain, and all of a sudden you believe that they're referring to you or talking about you.
Yes, I think that's true. And I think that once that has happened to you once, then you're sensitized to interpreting other events in the same way. And there's a very interesting psychologist in Yale called Phil Corlett who says that psychosis is in some ways as a top-down phenomena, that you misinterpret a reality on the basis of your beliefs, and these beliefs may have been formed when you were acutely psychotic, and so I think it's undoubtedly there's an acute psychosis when there is a neurochemical disturbance, but it may be that sets in motion a psychological process which makes you more likely to misinterpret events, even when your neurochemistry is relatively normal.
Mm-hmm. What proportion of people would you say who have an acute psychotic episode only have one episode and then don't go on to get it recurrently? In
our evidence from a study called the ESOP study, which went for 10 years, I think we had about 15% of people had an acute episode. In fact, I remember we had one lady who, when we followed her up, she denied that she had ever been in the Bethlehem, actually. She said she had, when we reminded her, she said, "Oh, yes, I vaguely remember this." But she'd been in the Bethlehem for some months and had totally forgotten all about it. Maybe the denial was helpful to her, but certainly she had been well subsequently.
As you mentioned, dopamine is an issue, and we have all sorts of medications, largely whose job it is to decrease dopamine. And it's probably worth mentioning that some drugs like cocaine and amphetamines, they directly cause huge increases in dopamine acutely. And that's why it's known that they can lead to psychotic episodes. What about cannabis? Where is the link between cannabis and psychosis?
Well, two things come to mind. Firstly, drugs like amphetamine and cocaine, of course, they certainly can increase presynaptic dopamine, but it's not. They don't increase it hugely. You might get something or a 15 or a 20% increase. And it's but it's still, it fits in with the dopamine hypothesis that the more synaptic dopamine you have, the greater the likelihood of developing psychosis. But actually, you give people cocaine or amphetamine, they don't go psychotic immediately. And the paradox is that you have to give them it for a number of days. For example, like famous experiments in American prisoners were that they gave amphetamine to prisoners and they doubled the dose, and it would be over a week or maybe 2 weeks before a particular individual might develop psychosis.
When was this experiment done?
I think it was done in Lexington Prison in the 1960s.
Yeah, you'd have trouble getting it past an ethics board now, as you say.
No, not at all. And the reason, you wonder why did the prisoners agree? The prisoners agreed because they got remission of their sentence.
Wow.
Anyway, what I was going to say was that, on the other hand, if you give THC to somebody, you can make them have a transient psychosis very quickly, within an hour. And yet, paradoxically, it's been much more difficult to show any increase in presynaptic dopamine in people with THC. And you can show it in animals, but in humans, there's been, I think, about 4 studies, and 2 have shown a small increase, and 2 have failed to show any increase. So it's still controversial whether the effects of cannabis on psychosis are mediated by dopamine or not. It's one way of thinking about psychosis is that the pharmacology, most of it we know from the drugs of abuse. For example, amphetamine causing psychosis gave rise to the dopamine hypothesis. Ketamine causing psychosis gave rise to the glutamate hypothesis. LSD and hallucinogens causing, I guess, a visual psychosis gave rise to the idea that serotonin was involved in psychosis. So it's possible that disruption of endocannabinoids could be involved in psychosis as well. Whether or not that would be through the dopamine system or not, we don't know.
So there's still another potential mechanism that's not necessarily well understood.
Oh, there definitely is, because you meet people who are psychotic and you study their dopamine system and they don't seem to show the usual excess of presynaptic dopamine.
And then, of course, there are patients who don't respond to the usual antipsychotic drugs, but do respond to another drug called clozapine, which is normally used as a last resort. And typically we call those patients treatment resistant. But now there's some idea that rather than being resistant to treatment, it's still yet another mechanism of action. Do you think that's the case?
Well, it is one possibility. And a nice lady called Arsimi Demjaha, who was a PhD student of between Oliver House and myself, she showed that people with treatment resistance did not show the usual dopamine excess, and that she and Alice Egerton showed that instead they seemed to have abnormality of glutamate. So this gave rise to the idea that some of these patients might have a glutamatergic disorder. And that would fit in with the idea that, say, for example, hypoxia or childhood insults could result in an abnormality of the glutamate system. And Arsimi suggested that these some of these treatment-resistant patients seem to have more neurodevelopmental problems. So that is one theory. And of course, drug companies have been very interested in glutamate drugs which would alter the glutamate system. However, in practice, they've been hopeless. So the drug companies have spent billions of dollars trying to develop drugs that affected the glutamate system, and none of them have been successful in coming to the clinic in relation to psychosis. So I think that is possible as one contributor to dopamine, to treatment resistance. The other, which I think is our other eccentric view, is that it's caused by the treatment, that it's caused by antipsychotics. And that people who have psychosis start off with an abnormality, a presynaptic abnormality, and they produce excess of dopamine, and we block its effect on the receptors by giving antipsychotics. And we've always rather assumed that this doesn't affect the receptors. But we know that from animal studies that if you block the dopamine receptor, then you get an overgrowth of the dopamine receptor. And in animals, antipsychotics lose their efficacy. The longer you give an antipsychotic, the less effect it has because of the upregulation of the dopamine receptor. And I think this may be the reason for the development of dopamine of resistance to dopamine blockers in psychosis. One possible reason why, again, this is an eccentric view, but my own view is that it may be that clozapine works because it reverses this dopamine supersensitivity, this upregulation of the receptor.
Mm-hmm. And would that therefore imply that aside from different kinds of medications, like clozapine being an example, that we should also be doing whatever we can non-pharmacologically, that is to say, socially, psychologically, to reduce stress, increase resilience?
I think when I became a consultant in the 1978, many decades ago, I took over looking after people from a consultant who had believed in megatherapy. And that is to say, he believed that if a patient did not respond to a high dose of antipsychotics, you should double the dose. So normally we would think of in these days that 1,000 milligrams of chlorpromazine would be the maximum dose that would be in the BNF would be acceptable. But some of the patients I took over were getting 3,000 or 4,000 milligrams chlorpromazine equivalents, and I thought this is a bit. These people are getting too much medication, so I started to try and decrease it. But some of the patients relapsed, even though they were still getting 2,000 milligrams of chlorpromazine. So I think once you get a very high dose of antipsychotics, we may cause changes in the receptor, which can only resolve very slowly. So it's a good argument for always trying to keep the dose of antipsychotics to the minimum.
Mm-hmm. And I think, that was a time when psychosis and schizophrenia was very much thought of as a biological disorder. But now I think there seems to be a trend of realizing that a lot of the dichotomies that we've been presented are actually false dichotomies, and that rather, instead of something fall into one category or another category, it's more a question of how the different categories interact. So, for example, how one's biology interacts with one's psychology and one's social circumstances. And you can even apply it to the nature-nurture discussion that we were having earlier, that it's not so much is it nature or is it nurture, or how much nature or how much nurture, but rather it's more a question of how is nature interacting with nurture, and then what's the end product as a result, because they're processes which affect each other dynamically rather than two static components coming together.
Yes, I agree with that. Again, when I started studying psychosis, researchers were seeking the cause of schizophrenia, thinking that there would be one cause, and therefore there were some that said, "Oh, the cause is genetic, and it would be one gene," and others who said, "No, it's a particular environmental factor." And now we know that there are lots of genes, and there are a number of different environmental factors, and that they interact, and there is interplay. Again, you think, we know that child abuse has terrible effects on some children. Other children seem to survive it. Some children who are affected develop personality problems. Other children develop a PTSD or addiction problems. Other people are prone to depression, and other people develop a proneness to psychosis. And we just don't really know, is it the nature of the abuse or is it some biological susceptibility? Well, one day we'll know these things.
What do you think has surprised you the most over the course of your research career?
Well, that's a very difficult question. I think so. I've been surprised that we've learned a lot from epidemiology. When I was young, I was an exclusively biological researcher, and I had a young research fellow called Everard O'Callaghan, who's sadly died since, and he said to me that the future was epidemiology, and I said, "Everard, this is ridiculous. Now we've had epidemiology for 100 years, and it hasn't taught us much, and but we've had brain scans and molecular genetics for a very short period. We'll learn much more from them." So I've been surprised at how much we've learned from epidemiology about risk factors. The other thing, of course, sadly, I've been surprised, is that we've learned a lot about the nature of psychosis and the biological underpinnings of it. And we've learned so little that's been of help in the clinic, that in terms of developing new drugs, things have been rather disappointing. We have drugs which are much nicer than it's much less unpleasant to take something like clozapine or quetiapine than haloperidol, but one couldn't say that these things have transformed the care of people with psychosis. And again, the psychological approaches, I'm a great advocate of cognitive behavior therapy, but it has a modest effect on average on patients. So we haven't had dramatic breakthroughs in care. Though, as I say that, I remember when I was a medical student, I lived in a psychiatric hospital for 2 years because we got free board and lodgings while we did physical examinations on the patients. And of course, the patients in that big asylum were there for 5 years, 10 years, 15 years, 20 years. And in many ways, that the asylum was their home. And the staff felt it was their duty to try and contain the psychosis and prevent it getting rapidly worse. It never entered their minds that patients might, that the psychosis might resolve and that the patients would be able to return to life in the community. So in many ways, the social care of people with psychosis has greatly improved, and we're much less pessimistic. I get very angry with psychiatrists who think schizophrenia is a degenerative progressive disorder. If you believe that, then you tend to act on that to the detriment of your patients. And you tell relatives that it's unlikely that your son or your sister is going to be able to return to normal life, and has a very adverse, pessimistic effect on patient care.
So it becomes a self-fulfilling prophecy. If you treat a patient like they have a degenerative disorder, they often progress as though they do, whereas in fact, having a more optimistic outlook might encourage a team of clinicians to put interventions into place which could have a significant impact.
Yes, and I think the early intervention is founded on that basis. And if we come back, sorry to be like an old record, come back to the abnormalities of presynaptic dopamine, we know that these can be exacerbated by stress, or they can be exacerbated by drug abuse. So if you resolve the cause of the stress, or you remove the drug abuse, then gradually the system can begin to recover. And therefore, it's not the case that it will necessarily progress. I certainly have no time for people that think schizophrenia is associated with progressive structural brain changes. I think that there's very little evidence for that.
Mm-hmm. And of course, it's a huge concern that I think psychiatrists in acute wards see all the time when they observe patients who come in an acute psychotic state, are well treated on antipsychotic medications, improve, and then subsequently are discharged back to very difficult social situations. For example, temporary housing, where there may be a lot of drug use and a lot of criminality, a lot of stress, very little support. And in those conditions, those are the perfect conditions for that psychosis to reoccur. And then when you're looking at it through that lens, one can't help but see psychosis as very much a social issue as much as a medical issue.
I think there's a lot of truth in that. And it's a paradox that we know that people with psychosis, with schizophrenia, are acutely sensitive to social stress. And yet, as you've just outlined, we often place them in places which are extraordinarily stressful, hostels with drug abusers there, or places where they're in poverty, they're in the most difficult part of town, they're socially isolated. These are conditions that most of us would struggle to cope with, and yet we are more robust. So I think it's certainly the case that in a sensible world, a sensible world, people with psychosis would be living in a nice house like me, away from the stresses that they often are placed in by living in some very cheapskate hostel that is all the social services can afford. I suppose the other question is, to what extent are we as psychiatrists mopping up socially induced psychoses? Well, certainly I think as psychiatrists, we're often treating depression when that is caused by the inequity of our society. And I personally believe that is the case also in psychosis. If you're rich and you develop paranoia or you develop some psychotic ideas, it's much easier for the family to cope with that, or even for it to resolve, than it is for somebody from the poorer parts of society.
There's a gradual awakening to this idea of how inequality affects so many conditions, even ones which are thought to be so biological, like diabetes and obesity, for example, which we're now starting to realize is linked to social factors, like, for example, what quality of food do you have access to, and what's your overall lifestyle, and how does your social position dictate that?
Of course, sure. I mean, it's all very well to tell our patients, who often become obese, partly due to the antipsychotics and partly to their lifestyle. It's easy to tell them you should be taking fresh fruit and vegetables, but of course their reply is, how do I afford strawberries, or how do I afford the avocados, which middle class people like me accept as the norm? So I think that is it's a very important issue, I think, in psychiatry and in relation to the care of people with psychosis.
Avocados are the quintessential example for sure. And I don't even think it's so much as healthy food being expensive as much as bad food being extremely cheap, and the ability to feed lots of people on very nutrient poor food. I'm conscious of your time, but just to wrap up, what do you think would be most useful for a member of the general public to know about psychosis or schizophrenia?
Well, I think to know that it is a reaction, as we've discussed, that it is some people are more susceptible to particular adverse events, but everybody can go psychotic. And it's not that people who develop psychosis are like people from Mars, men from Mars, who are totally different. This is something that many of us have the ability to develop psychosis in extreme circumstances, but also that once you develop the psychosis, then there's every hope that you should recover from it as well. So I think in the UK, the tabloid newspapers have done patients with psychosis a great disservice by painting them as if you ask the average person in the street, what does the term schizophrenia mean to them? They think it's a madman with an axe. And when we know that patients with psychosis are much more likely to have violence done to them than for them to do it to anyone else. And the patients who do violence are predominantly drug abusers and alcohol abusers.
So a lot of misconceptions that remain to be cleared. What research do you see going on in the field now that you're excited about?
I am very optimistic about, I'm much more optimistic than I used to be. I think molecular neurochemistry is beginning to help us to understand brain function, and also it's coming nearer to psychology and the merging of psychology and neurochemistry, I think, will be particularly productive. I'm very interested in epidemiology and in gene-environment interactions. I mean, that stands to reason that that is very important, but it's been very difficult to study that. I think one of the reasons is that research in psychiatry is typically small beer. If you think of clinical or epidemiological studies of cancer or of diabetes or coronary artery disease, then these are studies of hundreds of thousands of people often across different countries. Somehow the average cardiologist or the average oncologist has been brought into the research process so that you can get data on huge numbers of people. Whereas in psychosis, we tend to be dealing with, we're pleased if we get several hundred patients. Or we've been very pleased that we did a study across Europe where we got 2,500 patients. But a diabetologist would laugh at that you really need very big samples to fully elucidate the heterogeneity of these common conditions like diabetes or coronary artery disease or psychosis. So I think once we get the scale up and we integrate social and psychological epidemiology with biological markers, then I think we'll be in a much better perception to begin to delineate the different causes of psychosis, to the extent that I would hope that within a few years we would abolish the term schizophrenia. I think it's schizophrenia in my mind is stigmatizing, and I personally have not met a patient who was pleased that I gave them a diagnosis of schizophrenia. So I don't do it any longer.
And your hope would be that the term is replaced by a more individualized diagnosis, that it will be broken up into smaller, more specific conditions?
And indeed, a formulation. I think in some ways formulations are at least as important as diagnoses. If you or I were to develop a psychiatric illness, would you be content to have it described in one word? I think you would want your treating psychiatrist to understand your background, your susceptibility, your adversity that happened to you, and the particular pattern of symptoms, rather than say that you had schizophrenia or borderline personality and go into automatic mode in treatment.
Precisely. I think that's a common to everyone, that no one wants to be reduced to one or two words, but everyone wants to be seen as the individual that they are ultimately. Well, I think that's a very nice note to end on, and I just want to thank you so much for your time. It's been very useful.
Okay, thank you.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.